Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour, and Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community. And since we are live, I do want to remind everyone that we do take questions throughout the session. So do type those questions in as you think of them. Don't feel we need to wait until the end. Just type those in as you think of them, and we may take them at any time. So, and if you do feel like sharing your thoughts on Twitter, which we encourage you to do, be sure to tag us at Children's Healthcare Canada at Child Health Can is our handle on Twitter. All right, so today we're going to be talking about past, present, and future, striving to continuously improve access to autism diagnostic assessment. And this is a great presentation that we're going to have today. It's work I was just telling our presenters we've been sort of following for quite a number of years. They presented in a couple of poster sessions at what was the CAFC conference over a number of years, winning an award one year with their work related to their autism program. So now it's going to be our chance to hear about how they've transformed that program to all sorts of great outcomes, reducing wait times and other great things. And we're also going to hear part of the presentation is about how they've transformed themselves into a program with a continuous improvement culture. So I think we're going to have a little bit for everyone here in this presentation. So without any further ado, it's my pleasure to introduce our panel today. We have a team from Alberta Children's in Calgary, Alberta, and joining us we have Shauna Langenberger, who is a clinical nurse specialist and quality consultant in the clinical quality improvement work in the Calgary zone of Alberta Health Services at Alberta Children's Hospital. We also have Dr. Jean-François Lemay, who's a developmental pediatrician at Alberta Children's and is also a professor in the Department of Pediatrics at the Cummings School of Medicine at the University of Calgary. He's also currently the co-director of the Global Child Health Unit at Alberta Children's Hospital. And finally, we have Diane Hill, who is a registered nurse and unit manager in Child Development Services at Alberta Children's Hospital, all of them, of course, coming to us from Calgary. So it's my pleasure to hand the virtual podium first. We're going to hear from Diane Hill. Over to you, Diane.
Thank you. Dr. Lemay, Shauna, and I are all excited today to have the opportunity to present to you. We will share with you our past, our present, and our future, the work that we have done to improve access to autism diagnostic assessment at Alberta Children's Hospital for one cohort of children we see. We'll share with you the current work that we are doing and our expectations for continued work and success. In the past, we began with no clear understanding of the number of referrals we received, how long referrals sat before families were contacted, and what was actually done and by whom when we did see the children. We had wait lists for each discipline to see a child, resulting in a total wait time for families from 12 to 24 months, depending on the number of staff members that families saw. And for some families and children, the questions they came with were never answered. We'll walk you through what we did to achieve the outcome of contact with families within 7 days of our receipt of referral, a wait of no longer than 2 months for a family to be seen, and a process that resulted in every family leaving with the answer to their question. And this was all done with no additional resources being hired. On first glance, our path seemed like an insurmountable mountain, which we chose to climb. At this point, I'm going to hand it over to Shauna.
Thanks so much, Diane. So some background information, and the first being is you'll see on the slide here is we refer to our early project phase in Alberta Health Services, so AHS, applying our quality framework as define the opportunity. So a little more background here. So in the summer of 2013, I was approached about doing some QI project work with Child Development Services. Key issues described to me were referral management challenges with a waitlist concern. I was made aware that some work had taken place, but was informed that it really wasn't successful. So my first task was to do a comprehensive current state analysis. I was also informed that there was a scheduled plan to implement an electronic scheduling system as part of a site-wide rollout. So there was a time-pressured element related to this work. What I discovered, in addition to the opportunity for a lot of process improvement, was that there was a lack of service model clarity, namely who and what is our business. Based on my findings, I presented the project options, which were option A, a Band-Aid or a short-term focus, or B, a complete and comprehensive redesign. The senior sponsorship requested the redesign. What was also readily apparent from my review was the culture and some very strong opinions that weren't entirely consistent with the path that I envisioned ahead. So change management was going to be a very important aspect, as it always is, to ensuring the long-term sustainability of any changes that this team undertook. Had undertaken. And what were some of those predominant culture characteristics? Two that I'll share. One, a feeling that our program challenges were related to insufficient program funding, and more money will fix everything. So no real QI thinking lens at this time. And second of all, by the way, if we don't like the project, no worries, we'll just wait it out and eventually it goes away. At the same time, a really significant amount of work was transpiring within Alberta Health Services, and specifically Alberta Children's Hospital, focused upon ambulatory care and access. And I'll mention more about this shortly. So the scope of the project was then to complete a comprehensive redesign of child development services, and within this tackle referral management and the ASD diagnostic wait list. The decision focusing on our youngest population, 12 to 39 months.
So yeah, sorry.
Go ahead, Jeff.
Okay, so basically the context is that it is important to mention that Alberta has a population of about 4 million people. And of those 4 million, there's about 1 million that is under the age of 17 years of age. Therefore, it is well known that the pediatric population has been increasing quite rapidly, especially in southern Alberta. In fact, the projection that we did in 2010 were wrong. And I guess this is not the first time you're hearing that some projections are wrong. But to make it clear is that I think overall we are facing an important growth in our young population, and we're expecting to have even a more important challenge with this population by 2020, but even by 2027. The prevalence of autism in Canada has increased over the past 2 decades, with a recent estimate in Canada being about 1 for 94 patients. So we know there's an increase. We don't know exactly why. We are certainly better equipped to diagnose or to face the music when it's time to deal with autism. I'm not sure if we're able to offer the adequate support and resources after. But what is very important to remember is that the expectation from the parents regarding the opportunity to receive service at the right time, at the right time, at the right moment is actually very important. So again, timely service delivery is very crucial and important to be aware of.
So here I have 2 images pictured. First, the one to the left is our Alberta Health Services Alberta Improvement Way, or QI Methodology framework. And the image to the right is our AHS Path to Care Ambulatory Care Improvement Model. So just a little bit more about how they inform this work. So the Aiw Methodology is an AHS-wide quality improvement framework that represents a hybrid of improvement theory, and its aim when it was created was to create one provincial model that could be applied across the organization and used at any scale or measure of improvement activity. And a further goal was to create a common language so that over time it would be easy to bring teams and different stakeholders together, and we would be using a familiar framework and that common language. And to be clear that this is not just a lean/process improvement model, it builds considerations for the incorporation of evidence-based practice. It's easy to apply liberating structures or design thinking within this particular model, and this was our model of improvement that we followed for this particular project and continue to follow to this day. And second of all, I mentioned that AHS and the Alberta Children's Hospital had been involved in a considerable amount of ambulatory care improvement work, and the AHS Path to Care initiative, which is, again, this is their diagram here to the right. This work stems from two major reports generated through the Health Quality Council of Alberta, one in 2013 and an update in 2016. And the goal is to establish consistent and baseline set of standards for ambulatory care within Alberta. And essentially, this team at their baseline assessments was about 20% compliant with those standards, and at the immediate conclusion of our project had risen to about 87% in terms of their compliance. Another really key element is, and it was captured there in our improvement methodology framework, is we have a AHS designated change management framework that we utilize. So it's the ProSciAD card model, which incorporates 5 key domains: awareness, desire, knowledge, ability, and reinforcement. And the cartoon reads, any business change requires individuals to do their jobs differently to be successful. So with this framework comes a whole plethora of tools, assessment, implementation tools that you can use at any one of these 5 phases. And this was our change management model that we adhered to through this work. And lastly, this slide seems a little bit overwhelming, which is correct in that it definitely reflected kind of the feeling of the team and the leadership at the outset of the project. So really, what was our missions? So in the end, a complete service model redesigned. Our initial work focused on creating a program logic model addressing the who and what is our business to set direction for the team. And then a team focus really became the next phase of the work. So unpackaging the current state, which frankly meant asking a lot of questions, starting from how we manage referrals, talking to our referral sources, what did the initial parent contact look like, how were we communicating with families, really digging in to be sure that we understood the problem or problems that needed solving, asking why a lot of time, and collecting information and obtaining data, which at this time and place meant manual data because they had very few electronic systems in place. So validating the history, relationships, and culture, know your team and the environment, and essentially use all that you can together to access and fully understand the real problem that needs solving. We talked to all staff in every role. Working groups were composed of frontline staff. The people that do the work transform the work, in the words of Mark Murray, who's an ambulatory care improvement doc and specialist. And from our primary working groups, one or both of our physician and operational leaders was present and attending those meetings. Really important for people interested in undertaking this work. So adhering to the improvement methodology and process is really key, especially at these early stages. There's always a lot of enthusiasm. As clinicians, we're movers and shakers and we're doers. And often there's a rush to start doing work before we fully understand. And what this means or translates into, it's do it once or do it again if we're not taking that essential time. Or what ends up happening, which was what happened with this team, is we're focusing on the wrong work. We're not seeing any improvement, so why are we feeling discouraged, right? So no proper root cause analysis. The other piece that was really clear in this work was adhering to the early messages that we obtained from families. So here were essentially our specific marching orders that families had provided us. So you need to do whatever's necessary to ensure we get a diagnosis as soon as possible. We were very transparent about the current challenges, and parents were also very clear: manage your people, change what you need to. This is about us. Share the diagnostic process with us. We want to understand what is going to happen. Please help manage our expectations. Be clear on what services and supports that you provide and what you don't provide, and help us connect with other families. Teach us how we as parents can support our children. And these really are kind of our ongoing mantras with this clinical program.
One of the first items that Shauna helped us create was a value stream map. And you see a picture of that on your screen, outlining the steps in our process from the receipt of referral through booking appointments, assessments conducted, to a final diagnostic conclusion that a family received. Once the value stream map was complete, we gathered data, still manually at this point in time, to calculate how long each step took and the time that families were waiting between steps in the process. This visual put our current state and opportunities in plain view for the whole team to see. And so at this point, there was no denying that there was a need for improvement. We learned that the support and involvement of our leadership dyad was critical for our team, our QI consultant Shauna, and ultimately the success of our work. In the past, management had not been consistently present to this team, and there were no child development physicians involved in this team's work. So the medical operations lead and the clinical operations manager worked together to support and be present to the team. We respected their work, and we accepted accountability as the managers for the improvement being planned and implemented. Every referral is the story of a patient and a family. This reflects a critical change in perspective, strongly emphasized by our medical lead. So if the value stream map that you saw in a previous slide was powerful, hearing from families directly cemented our need for change. We shared the good, the bad, and the ugly of our current state, both with families and with community partners. Families' needs versus what staff felt was needed developed the requirements of our future state processes. And a key element to the new diagnostic process for our young children was enhancing parent education. Parents attended classes before their child's first diagnostic appointment, and for those parents whose child was diagnosed, attending an after-diagnosis session as well. Surveys evaluating the value of the educational classes for parents were undertaken. A large project was done in 2015, where 68 families were contacted and represented a 71% response rate. Participated in telephone interviews to evaluate the overall diagnostic process. This information yielded extremely favorable results and information for us going forward. While staff were somewhat hesitant to move to mandated sessions, when surveyed, 100% of the families expressed value and appreciation for attending the sessions with other parents. We continue to evaluate the family experience today and to follow a number of metrics focused on ensuring that we meet our performance goals. JF, I'll hand it over to you.
Perfect. So on this slide here, this is our act to improve. And I do acknowledge that it's maybe difficult for you, reader at this moment, and listener to look at this. But the message I want to tell you is that we heard it from not only the family, but also our colleagues or the other professionals who are working with us on a daily basis. It's basically, tell us exactly what is your process. Show it to us. Make it sure that it's easy to follow. And the bottom line, I think we were quite successful by doing it. And I think overall, it was not difficult to sell when you have a graph, a flow chart that is very clear and precise. So in other words, I think the family wanted to know exactly what was the diagnostic process, share it with us, and we did it. And basically, we also share it, and the next slide will show you that recently, we have published in August of 2018 an article that we call the redesign of our ASD screening and diagnostic process for the children under the age of 3. And basically, overall, I think that this article summarizes very nicely what we have done. We will discuss briefly in the next few slides what we have changed. And I will just add here, it will be our pleasure for those listening to this webinar. We will be delighted to share the link of this article with you. And I think overall, we were very pleased with the response of this article, where actually I just counted about 85 emails that were sent to us and asking us questions and praising us about what we have been doing. So I think overall, it is important to somewhat share not necessarily the process, but also what we have done. And we did it with our flowchart and the article. So I'm going to pass it back to Diane about exactly what we have changed.
We have changed what we do and how we do it. Rather than accepting referrals with a one-line question of query ASD, we created a referral form using the DSM-5 criteria to guide the information requested of referral sources, so that from the beginning, we can understand a child's presentation and the needs that they have. Educational sessions for parents became mandatory as the first step before they actually proceeded to screening and assessment. We created a standardized process that was implemented. That standardized process included tertiary screening and a standard process for assessment and diagnosis. This standardized process resulted in the right patient being seen at the right time and seen by the right provider. We gathered data and conducted evaluations to confirm that our work and our improvements met the family's needs. And we have focused on sustainability from the beginning and changed our culture of quality improvement for the future. Things are now quite different. Clinical operations and physicians are involved in a collaborative approach with members of our team. We communicate about our patients and we communicate with each other. We work in a very collaborative working environment together. All of us now take on ownership for the children that have been referred. And quality improvement has become the lens through which we look at any problem that we see. We find a problem, we take a look, and we start to ask various questions about why and how it can be improved and addressed. And we take time to celebrate our work together.
So I think what is important, and let's do it right now at this midpoint of this presentation, is that, yes, we're telling you a very success story, but you may ask, how have we been able to achieve this? Why? And we were just reflecting on this success story. And I think overall, our message to all of you listening to us is that we believe very strongly this is a combination of the use of a methodology, which is combining our quality improvement approach, plus also reviewing the literature, what we call evidence-based practice. I think this combination is quite a good way to implement any practice innovation that you might be interested to do in your own center, or an opportunity for you to building up tier physician and stakeholder collaboration. And if we go on the next slide, as Mr. Menard says at the beginning, yeah, we were awarded some very nice recognition about our work, but one that we would like to share is the Alberta Health Services President's Excellent Award in Quality. And this is our team. So there's a lot of people, and some of you may say, well, there's a lot of people involved, but you know what? It is important. Everybody has something to say, and we think overall that this has been one of the reasons that having strong collaboration is certainly with the use of a correct and adequate methodology. We felt that this is the reason why we were successful. And now we're going to talk about now the present and how we're doing presently. So as we mentioned, in 2015, we did a survey of some parents, and we received very good feedback and great kind of comments from the parents. One of our success at that time was that our wait list that was about 18 months when we started the project, well, I should say before even thinking about implementing a project, was reduced within the first 6 months to almost under 2 months. I am pleased to report to all of you today that we're still 5 years later able to manage a wait list that is still under 60 days, even sometimes between 20 to 35 days. So we did a recent evaluation, and the next slide will show you that overall we had two significant goals. One was to obtain, of course, feedback on parents' experience during our screening and diagnostic process. This is very important. It is serving parents, knowing what they're thinking. I'm a strong believer into it, and I think I will strongly suggest to all of you to once in a while to say, are we still doing okay? Accepting the status quo from my point of view is not something that we should aim. The second is, okay, great, you diagnose these kids, and if so, are they able to access services? And in Alberta, we have two different kind of services. One is called the Program Unit Funding, or PUF, or the FSCD. We're going to show you 3 quick slides that will tell us about the success, I think, of our story that seems to continue. The first one is about our educational session. Diane mentioned to you at the beginning that it is mandatory for the parents to attend an educational session about 3 hours, telling them more about what a child is supposed to do under the age of 3, features about autism. And if you look at these numbers, again, for all of those questions, do you feel these sessions were useful? Were you able to ask questions? Or were you satisfied? Were you happy with the materials were provided? If you look on the first 2 columns, if you added these 2 columns, all the numbers are very high. They're over 90%. And the session, that's the last line, 93% felt that these sessions were quite useful. The next slide will show you that regarding the screening, so we have 2 components. We have the screening and the diagnostic kind of assessment process. And overall, these 2 components, again, look at these very satisfied numbers, over 93 and 95%. And overall, when we ask the parents, tell us about those 2 sessions that you're spending with us, 92% felt that they were overall very satisfied. So for us, this is a very nice reward. The next slide will tell you, are they able to access services? And you could see on the left side is that over 95% are able to access what we call the PUF, or Early Intervention Program. And on the right side, 90% are able to get even more hours through what we call the Family Service of Children with Disability, or FSCD, or in our common jargon kind of terminology, specialized services. And overall, the perception of the parents, are these services helping their kids? And you could see that their top 3, they're saying yes, and they're saying it's helping them with communication, social interaction, and overall behavior. So I think overall, what is important to be aware of is that we are a strong believer that serving these parents, getting feedback from them is so important. And I should say that we receive also some very important qualitative comments or materials from the parents that we're going to be using to continue improving our assessment process. So Diane, now what are we doing presently?
Mm-hmm. Presently, we're continually monitoring our performance using the QI methodology that we have learned. In the past, we had no way other than by manual counting to calculate the number of referrals we had received and those who were waiting to be seen. We have been able, through some electronic databases, both one that is available to all of ACH and one that is specific to Child Development Services, we have been able to track those referrals. Currently, in about 60 seconds, our Central Access and Referral Management team can provide the information about numbers of referrals received, those who are waiting for service. They can provide that to us in about 60 seconds when asked. This data is posted weekly on our communication board that we have set up for all staff to be able to see and to monitor. As a manager, I have what's called the Business Intelligence tool from one of these databases, and this tool captures some of our past care performance markers. I use this data in my conversations with frontline leaders on a regular basis to confirm and manage those numbers and to start the conversation if we need to be looking at what we should do differently or understanding the problem more. And when we see a wait, we begin to ask the questions why and develop a plan to address the wait before it becomes large. Currently, we also have a project underway to address the next cohort of children from ages 4 to 6 who have been referred for a query of ASD. We are using AIW Core. This is a 10-week intensive program with regular meetings, full-day commitments by a selected team of individuals in the clinic, and a formal report out to stakeholders. We have a family advisor on our team so that we have family input from the very beginning. She has provided invaluable information and input to our work. And through the use of similar QI methodology that we used with Shauna, we have been able to critically look at what we do for this cohort of children. We have redefined our problem, created a short-term and long-term goal, a triage process, and defined 4 clear diagnostic pathways that has resulted in a clear plan for moving forward with these children. Our first test cycle of this work in the form of a plan, do, study, act cycle is currently being implemented in May and June of this year. And on the next slide, you will see our current AIW Core Improvement Team. We call ourselves the Awesome Sauce Dynamos. Our work is not yet done. Shauna.
Yeah, thanks, Diane. So some take-home messages. So using the quality improvement methodology and tools helped this team really dig in and evaluate their service in a way that had not been done prior. It raised some tough realities. We asked some tough questions and we challenged assumptions, all in an effort to derive the complete understanding of the problem. All staff were provided with QI education in the form of AIW Fundamentals course. The legacy piece requires that new staff are exposed to this improvement theory to continue to support the new culture of this program. And at the end of the day, it all becomes a discrete project if you're not focusing on this culture piece, right? And this is well reflected in the improvement literature in terms of like, how do we make organizational changes? We have to move away from discrete project thinking and really think about this is how we roll as a program group and organization. Leadership is critical, and an all-in approach is what's required. So the theory also reflects that those managers closest to the frontline staff are going to be highly influential, and we can certainly see that with JF and Diane. I mean, all in every day, this was a major focus of their work. The other aspect that this team has fully embraced is that they know that their involvement is essential to informing the work and making the right changes. So as frontline staff, we all need to be part of discovering and owning the problems and then informing the solutions. And, some additional take-home messages, really cementing that idea. This has become a real mantra for the team, is that each referral represents a story of a child and family searching for answers and support. So yeah, not just a piece of paper, but bringing that human. So, as you're handling that paper, this is what we're seeing. And we have redesigned our ASD processes to become more efficient, more flexible, and we are providing better access services and supports for families in a time frame that families feel is appropriate, not we feel is appropriate. And success cannot be attributed to simply one element, but this is the sum of a number of small changes that, again, teams are looking for that secret sauce or the silver bullet that's going to come in and change everything. There are some big level organizational changes, but it's all the summation of every small change that contributes to the substantive change and the long-term sustainability. Now, Diane and JF are going to share some lessons learned from their specific perspective.
So I've reflected on what lessons I've learned over the past 5 years, and it's amazing to think that it has been 5 years, and what I can share with frontline team leaders and operational managers. Our redesign of child development services helped us to start to become a center of excellence, to also focus on our work of assessment, and to leave the work of intervention to others who provide that service after we've answered the question that families have come to have answered. We acknowledge that looking at our work can provoke anxiety and fears about changes of roles on the team. Interpersonal relationships and valuing the contributions of those we work with is critical. It's critical to reducing resistance to new ways of working and to accepting the need for change. Families are invaluable in the work that we do. They are needed, and they need to help us understand what is important to them. There can really be a disconnect, which we saw, between what providers feel is necessary and what families feel is important. And without understanding our families, we really risk not providing them with what they need. Managers must state upfront what decisions from an operational perspective have already been made and are not open for discussion. This sets the stage for open and honest communication with the team members and is critical to accepting that management is part of the process. The use of ground rules in meetings has given me a framework for conversations and input, and it acts as a reference if conversations in a meeting become non-productive. We can refer back to the ground rules that we have set the stage. And I am proud to say that with our attention to people and to improvement processes, we have achieved significant and sustained change, and we continue to value improvement in our future.
From a medical point of view, I think we have to be honest. To address any problem within your clinic, I'm the first one to say that I was not well equipped. I knew there was a problem. I was very concerned about the issue we had with young kids waiting to be assessed for autism. And honestly, I think that it took me a little bit of courage to say, you know what? I need some help here. If I want to change something, I need to see what else can be done. And what I mean by this is also trying to seek for expertise, for people that will be able to guide us during that process. And that's why I was one of the first one to embrace the QI training offer at the Alberta Health Services. Yes, don't get me wrong here. It's time consuming. Yes, I was well supported by my department, but I think overall this is a key to shift the culture within your own center. And overall, you know what was the most important thing? Is that at the end, I felt that everybody was speaking at the same level. We use the same terminology, we use the same language. And what I did is that I made sure that I informed all of my colleagues on a regular basis. And I'm proud to report that, some of them have been able to embrace and even follow the QI training, which was quite important. I already mentioned to you a bit earlier that the combination of methodology using a QI approach and evidence-based practice, I think I'm totally sold to it. But I want to be clear, testing new ideas will take time. And yes, when you will try to explain what you're doing to the others that are not necessarily aware of what's going on, it may be rough at times, it may be difficult, but you know what? Just be patient. Just be patient and just be patient. As mentioned by Diane and Sean, I think the role of leaders, I think that overall, this was a very important step in what we did to implement this very successful story. The dyad model, for my point of view, works much better when you have management and medical team working together. This has implemented a shift not only in practice, as we said, but also in culture. And now I'm going to briefly report about those words that I just put as my 5 and last lesson, my last bullet here. Accountability, so important. I think this is every 3 months, I'm asking myself, we have to make sure that we're accountable, that we are not accepting the status quo. That's why sustainability is so important. Respect, respect, and respect. This is so important to listen to the others. Again, one of the most important features was to get involvements of some families into our process. Be flexible. Yeah, sometimes you think you have a great idea, but you know what? Overall, it may not be the best one. So the flexibility of the process. Yeah, we may have a nice flow chart, but sometimes we have to be a bit more flexible. We did this with the English language learners or those immigrants that are coming to Calgary. Calgary right now has over 27% of new immigrants within their population, or they were not born necessarily in Canada. So flexibility within the process, it is something to be considering on a regular basis. Communication. This is what we're doing with you, all of you listening to us. And I must say that one of my colleagues today, what Diane mentioned about the 4 to 6 at noon, will be presenting to all the medical doctors within my team about what's going on with the 4 to 6. So what we have done is continuing to be, again, what I call the gold standard. And efficiency. Again, I don't want to say that we're efficient, but let's put it this way. I'm proud of the work that has been done, and I'm so pleased to report that our wait list is still not very long and that people are accessing services. And overall, as we presented to you, they're very satisfied with us. So overall, I will let my colleagues just to mention maybe one or two more things, and we're going to have a period of questions. So Shauna, do you want to just briefly conclude, or Diane?
Sure. Yeah. So I think that's it, right? Again, this is Shauna, and I'll speak on behalf of Diane and JF myself, right? What we've tried to do is, rather than just focus on results achieved, really try to share some of that secret sauce, the process, the steps that we've undertaken, and really help you understand, how things are different here. And I guess, Doug, we'll turn it over to you as the moderator, and we can potentially, we design this process to leave, or presentation today to leave time for questions. So we'd like to proceed to that now.
All right. Well, thank you very much. Great presentation. And I think delivered on everything that we talked about at the beginning. I mean, really talked about the practical things that you did to change the program, the culture change and everything. I think you're just a fantastic presentation. We did have a couple questions in particular about some of the slides. The slides are available there's a little handout section of your control panel. In particular, they were looking at that very complicated flow chart slide, and I checked the PDF that's there, and it is quite clear in the flow chart, or in the slides, that process flow chart is quite clear. So you should be able to get a good look at it there if you download those.
You can see that in the published article also has a very clear representation of the flow chart and the actual process as well.
In fact, in the article, the flow chart is even more self-explicit. It's actually having every single step and even more explanation. So what is on the slide is actually, it's a very good summary, but in the article, I will say to all the listener that it is even more explicit, and reading the article at the same time as looking at our flow chart, I think will be very beneficial to all of our listeners.
Oh, was there a link to the article in the slide?
Yes, I just need to somewhat create it. I'm the only one who has access to offer a link, so I'll be able to do it within the next 24 hours. It's just with copyrights and everything. I just need to make sure that we're following the adequate rules. So I'm sorry for asking for just being a little bit patient about it, but there are some copyrights that are still in effect within the next 2 years. So I just have to be very careful here.
Yeah, no, absolutely no problem. And if you are able to share that with us, we can.
I'll be able to share. I'll be able to share. I just need to say to all the listener, I'll be able to share the links with you. All I'm saying to you is that those who will be, using this link, it has to be for your personal or for a specific reason why. It cannot be distributed during any other presentation. And that's part of the copyright that we sign. I just want to be clear.
No, that sounds good. I'm sure people will appreciate it nonetheless for their own sort of personal use, for sure. So the next, we did have a couple questions that came in about, so what happens after 3 years old? And then shortly after you answered, or those questions came in, you went on to talk about the 4 to 6, which was, again, really great to see that. I mean, we see so much emphasis on that early intervention and early diagnosis, and a lot of times people run out of energy, run out of money, and that's sort of where it ends. The improvement is in those early years, and then those 4 to 6 and 6 to 8 and 10 sometimes sort of suffer for that. But it was great to see sort of the long-term vision that you guys have created there.
Well, and further to that, just to be clear to everyone, with the measure of efficiency because we had wait lists, throughout the program at that time. With the amount of capacity that we had gained back with the efficiencies in this group and some of the other teams, we had wait lists at all of those, within all of those population groups, but we had worked down all of those wait lists within a short order after we had implemented these new improvements. And then, we're continuing to strive to make further improvements and manage any potential wait list with these older populations.
And I just want to be clear regarding the respect to wait time. Our target was about 28 days from parent sessions to screening appointment, and a cycle time of about 3 weeks from screening to diagnostic. I would say that this was accomplished without any additional human resources and has remained sustainable up to now. So you don't need necessarily to implement or add even more resources. Use what you have, and I think we have been quite creative. So this is my personal thoughts here. And I think overall, this is another message that we would like to provide to all of our listeners, that, you don't need necessarily to add more resources. No. Think about what you have right now, and you will be surprised that sometimes you may accomplish the same, you may accomplish the same kind of amount of when you're implementing a new system, you might be even more successful without adding any new money, let's put it this way. Diane, I don't know if you want to add something here.
I will add, when we began the process, what I would often hear from staff is the comment, we never should have seen this child. This child is very clear, or this child does not have autism. And that happened because, or one of the reasons it happened was because the referrals we accepted, we would accept query ASD without any additional information. And so those children ballooned our wait list and sat on the wait list, causing waits for everyone, whether it was an appropriate referral or not. The use of inclusion and exclusion criteria and the development of the referral form really helped us to be able to say, yes, this is an appropriate referral, or no, it is not. And with the changes in path to care, if the referral was not appropriate, we were able to get back to the referral source right away and give some suggestion for other places that a child could be seen, but recognizing that they did not need to be seen for a query of ASD.
And also what's important for all of our listeners is that we did reach all the stakeholders that were referring these kids to us. We sat with them. We made presentation to them. We explained our process to them. Was it time consuming? Yeah, it took us about 6 months to a year just to reach everyone. But I must say, this has been one of the most wise and, I would say, thoughtful idea that we have implemented in the process. So reaching your stakeholder, absolutely you need to do this. Explaining what you're doing, very important.
And it was not without pain. Certainly our
no, it was not.
they would often not want to hear that, no, we would not see their child, but by giving them some suggestions and recommendations going forward, over time it took a while for them to understand and accept, but to realize that the children that they were referring that needed to be seen could then be seen quicker.
There was just a request for clarification when you were talking about the 2-month wait time. Is that to the first education session contact with families, or was that to an actual diagnosis for the child?
JF, do you want to respond?
Yeah, so basically the 2 months wait time. So let me just explain. Maybe I was just a little bit, I really recognize I was trying to sort of speed up a little bit this. So by the time that we, our target days of 20 days is really 28 days is from parent sessions to screening appointment. But let's be clear. When we're getting the referral, with the path to care, we are very quick to respond, and we're reaching the parents. We're telling, first of all, the doctors, your patient will be seen. We're reaching the parents and saying, you know what, as you know our process, and the doctors usually explain this to their parents, is that basically you will have to attend a mandatory educational session. So we're very quick to provide opportunity for parents to come to the parent session. So this is basically something that is done, I would say, very within, 10 to 14 days. And then from the time that they're attending the educational session to the screening appointment, our goal is less than 28 days, and we are doing certainly less than 28 days. And after that, I would say that the average after the screening assessment is between 7 to 17 days before they see the diagnostic. So in summary, when you're adding all those days, within less than 85 days, the diagnosis, if applicable, is made for a child. And after that, information, documentation, etc., to get support and services are provided to the family within 2 weeks. So when you looked at it, when you have a referral, we are able to accomplish a diagnosis or to provide a diagnosis and provide documentation under 99 days, technically. And I would say we're successful with 90% and more of the cases we're seeing. Is that pretty clear? I mean, I know it's a bit technical about the stuff here, but overall, this process is very smooth. Actually, it has a beautiful flow. And Diane could say that this will not be done successfully without the people that are at the triage, or clerical clerk that are and administrative assistant that are working on a daily basis getting referral. I'll let you maybe comment about it, because this is so important within the success of the process.
Mm-hmm. Our path to care requirements are that we acknowledge receipt of referral within 48 hours, and we're able to do that 100% of the time. We must contact families within 7 days of the receipt of referral to make a decision about whether or not the child will be seen. We have the odd family where it is appropriate, but for one reason or another, a family does not want to proceed, and we respect their wishes and acknowledge that back to the referral source if that is the outcome after a conversation. Once then the referral is accepted into the clinic, the clerk proceeds to book the family into an education session. And we monitor those to make sure if there is a wait that is not a wait because the family is not available, that we can add additional education sessions as needed.
And I must say that for every month, we have a template with dates where the educational session will be provided. When we have the screening sessions, when we have the diagnostic process kind of appointment of the doctor.
Great.
So on a monthly basis, we can predict exactly. I could telling you right now what's going to happen in August. So we have the template. We know exactly when these sessions or when these screening and diagnostic assessment appointment are available. And the bottom line, this is making our life way much easier.
Just going through that process, someone's asking about when ASD is or the child has a dual diagnosis, with ASD being the secondary diagnosis. Is the wait time in the process and all of this fairly similar?
I'm not sure so the bottom line is that if there's a concern about ASD, so I'm guessing maybe the person is referring to the possibility of a child having a genetic syndrome or something else with ASD. If the concern is, again, related to ASD, whether or not this child is having a genetic syndrome or having maybe another possible medical condition, we're still assessing these kids, and this is not delaying by any days the assessment or the possibility of saying that this child has ASD. I don't know if I'm answering the question.
There's not a unique. All these kids come through the same demand stream. So they're a child that needs a diagnostic evaluation. They're not subsetted within that group. They all flow through the same process. And the specific allowances, if they are a family that has language concerns and that, again, there are accommodations for that, but the goal is to continue to see them with that same general process and flow and the same service and target expectation.
But again, I want to just add one more thing, Sean, if I may say. Yeah. We are still flexible. That's one of the messages we want to let all of you be aware. If you are able to, again, have some flexibility within your process, then it's useful. But as Shauna mentioned, we like to use our flowchart, but if we have to be flexible, so be it.
Yeah, it's one of the values of standardizing, again, the bulk of the work, because you gain back capacity so that when you need to address these special circumstances, you actually have the capacity to do so, versus building a process for each individual child, which is, the variation is highly inefficient, and you're losing a ton of capacity with that variation.
And I would say, too, that having physicians from child development as part of the work of this team, which had not occurred in the past, if there are other questions about genetic syndromes or other questions about other developmental issues that need to be addressed beyond the ASD, one of our physicians has seen the child and can pursue that work once the question of ASD has been answered.
And I must say that the support from the community pediatricians and other family medicine doctors has been wonderful, as well as the speech pathologists. I must say also what is important is that if the kid is not receiving a diagnosis of ASD and we're not so sure, we are having a process that we could continue following this child. And if this kid still is not meeting the diagnosis of ASD, there are multiple. We're fortunate in Calgary and Southern Alberta. There are different resources and support, or even different stimulation, or I should say intervention program that this kid can be referred. So it's not because if they're not ASD, or we just let it go and that's it. No, we're caring for every child that is coming. But I must say that the majority of the kids referred to us are getting out with diagnosis of ASD. Maybe this is because we have been teaching and training those making the referral, so they know that we're seeing the more complex one, or the one that are causing maybe more concern within their office or within their practice, so they're not so sure. I think we have done a great job by helping those in the community, identifying the kids that are pretty much meeting all the criteria of autism. So I think this is something that has been also, I'm very proud of this, and this has been another part of our success story.
All right. I mean, this has been such a great sort of conversation amongst the three of you. I think you've given such broad and diverse and detailed answers that we're starting to answer some of the questions that have come in later on. Like in particular, some people were asking about what happens to those kids that are not accepted in the diagnostic to the diagnostic process, and you just sort of indicated that there is still follow-up or information that's passed along to them.
Yeah.
So there's a few questions sort of related to the triage and referral process. I'm just sort of asking for a little more clarity on, so that you mentioned the DSM-5 criteria, just wondering what other information in addition to the DSM-5 criteria is required in the referral process? Like what else is there on the form? Is there a checklist kind of form or process that you've developed that includes the DSM-5 criteria? Just a little more information about that, if you could.
Jeff, do you want to talk about that?
So yeah, to make it, so the DSM, so our referral, I must say that it's a little bit time consumer for those making the referral to us, but I must say now that it's now part of the meal deal that we're offering, and there's nobody complaining about it anymore. But yes, within our referral form, there are questions related to about issues related to social communication, the repetitive behaviors. We're asking about is there anything we need to know about the medical history of this child? So it's a very detailed referring process. It's about 4 pages. It's easy. It's on the web. It could be also faxed to us. I must say that the physicians are also able to attach to the referral forms their recent visit, telling us more about the history of the child. We are also offering opportunity for them to even contact us by phone if they want to give us more information. So I'm just telling you, it's quite detailed. Was it an easy sell? No. But right now, I think it's part of the culture within the population that we deserve in Calgary. I'm talking the pediatric population, means that people are understanding about the importance of providing as much information as they can. So now I think that this is something that's more elaborated. It's hard to define again during a webinar exactly, but I must say, yes, it is quite thorough. It's asking almost every aspect of the childhood life, but in a practical way. So I'm not saying this is a pain in the half for those filling up. I think they understand the importance of having this information before we sing the kids.
And the only thing I would add is we also ask for an example of each rather than just a checklist, because we found in the beginning that a checklist only, everything was checked off, but we had no more information. And when we talked to families, it wasn't always consistent. So we ask for an example in writing of each one of the areas of the DSM-5 to make sure that what is being checked off matches with what we would be seeing within that piece of criteria.
And you know what we know? Sorry, Diane. Do you know what we notice also in the most of the progress note they're saying to us is now they're using this in their progress notes, and when they're saying something positive about maybe eye contact, and they will provide an example. So in some way, we have also changed a little bit the way that people are keeping or tracking their progress notes for those kids who are having maybe a suspicion of having ASD. So I think this has been quite interesting for myself from a medical education point of view.
If you, JF mentioned it's public facing. So if a physician Googles Alberta Referral Directory or Inform Alberta, you can click on our program information and the referral form is there.
Thanks, Joanna.
Right. We do have a number of people who are interested, or in particular, there's a group in Newfoundland that are wondering when you're coming out to visit. I was
I'll be
wondering.
there in September.
Oh, yeah, there you go. We'll have to make sure we make a connection. I was just curious as to whether you had contact information on a next slide, or where the best way people could get in touch with you if they are interested in learning a bit more.
Doug, I can put a summary and add a slide to this presentation if you like, and just send this to you within the hour, and you can send it out if that works.
Sure. And what we can do is we'll put that information up on the Knowledge Exchange Network, which is where we'll post the recording of this session as well as the PDF of the slides as well. So we'll make sure we get all that up on the Knowledge Exchange Network, and everyone that's attended the session today will receive an email with a link to that page, so they can access.
Can we just say thank you very much for everyone who took the time to attend. It's really our great honor to present this information to you, and we appreciate your time.
Yeah, and we do have quite a number of questions left. We are pretty much out of time, so we won't get through all of them. There were a number of people who were. We'll take maybe if you do have the time to stay for a couple more minutes. There are a number of people who are asking just a little more information about the 4 diagnostic pathways that were developed. Just if you could give a little sense of what those 4 looked like.
So I think that, Diane, there's specifically the 4 to 6, huh? Right now, the 4 years to 6?
It is, yes. Yeah.
Go ahead, Diane.
Sure. So the diagnostic pathways, we took a look at referral, we took a look at parent report, and based on that, we ended up with 4 different pathways. One that would, there's enough information the child would go directly to see one of our pediatricians in-house. Another pathway would be directly to psychology, and that often was because there were not either symptoms of ASD in any of the reporting, but comorbid mental health presentations, or the other reason for our psychology being involved is if there were very conflicting views and there also were mental health issues. We have one group of our staff that will see our speech language pathologists and occupational therapists, either because the child is in a school environment and there is evidence of ASD in the classroom, but the parents are not on board, and so there is some work done to observe the child and then provide that information to our in-house pediatricians to see and confirm a diagnosis or not. And then there is one group of children that is actually being seen by one of our 2 allied health that have been trained in the administration of the ADOS tool. And very often those families, they are children where families are not on board with the diagnosis, and there is no evidence of ASD in the classroom. But because the parents are not on board, we are using the opportunity of the administration of the ADOS by an allied health clinician, and then that information being relayed to our pediatricians in-house and a final appointment with the diagnostician. So the 4 pathways are our in-house pediatrician alone, our psychologist alone, our speech, language pathology, and occupational therapist observing and then seeing a pediatrician in-house. And then the 4th pathway would be administration of the ADOS by one of our allied health clinicians that is trained, and then an appointment with our pediatrician who is the diagnostician.
May I just add something that is an important message to all the listeners? I think one of our finding is that you don't need, I'm a strong believer, you don't need to do an ADOS on every single patient.
That is correct.
So this is a message, and for the patient, for the population under the age of 3, we're doing it about a third of the time. And I think the projection for the 4 to 6 is that we don't want to do it on every single one. No. That's why we have 4 different pathways. And I think this is the trend that has been now being promoted in North America. Every child does not, childs refer for ASD, they don't need necessarily an ADOS. And that's the big message. I want all of our listeners to be aware of it.
Yeah, that's very true, JF. Thank you for that.
All right. And I think I do have to apologize to the audience. We do have a number of questions that there's just way too many that we would ever get to. So I think this is probably a good time to maybe wrap it up. We will make sure we get some contact information to everyone so that they can follow. I hope you don't mind if people follow up with you directly. There are lots of very specific questions about the process and referral process, how connecting with community pediatricians, et cetera. So there's lots of great questions that we unfortunately don't have time to get to. But I did want to leave you just with one more chance to just close off and anything you'd like to send the audience with before we sign off.
I guess for me it would be that change can be achieved, and within that change and evidence-based practice and quality improvement, efficiencies can also be achieved.
I think from my point of view, I think the success in redesigning our autism spectrum and diagnostic process for children under the age of 3, I don't think it could be attributed to one specific element, as we mentioned, but was the result of all changes made. And in some, I think our QIP has led to efficient, I would say sustainable, and I would say evidence-based diagnostic evaluation process. So in other words, I think that, yes, you need to be systematic in your approach. Yes, it's going to be time consuming, but you know what? At the end, I still have a nice smile on my face. And my 2 colleagues, Diane and Shauna, who have been wonderful person to work with, I think we're still the best friend in this process, and we like each other. And basically, and it's been such a valuable learning lesson, not only from a professional point of view, but also from a day-to-day interaction, like friendship point of view. And also sharing and being passionate. I think this is what I want you to be aware is that working, if you want to change something, just be patient and also enjoy the changes. It's not easy for people to change. It's causing some issues. You're out of your zone of comfort. Even myself, I was out of my zone of comfort, but I must say it was worth it. And Shauna, maybe you want to conclude with this?
Really just amazing, gratifying piece of work. I have such an immense respect for, the leaders that I've worked with, all of the frontline clinicians. People are so passionate in serving this population of families and children that require support from the healthcare system. And it was really my great honor and privilege to be a part of this work, and continues to be a very gratifying piece of work that I have been involved with. And to see this team surge forward and continue to do this, wow, my heart is large. And to you, all of those of you out in Newfoundland, yeah, I am coming to Newfoundland in September, and I'd be really happy to meet with you.
Be sure to do our best to make that connection for you. So,
Yes.
So thanks again. Like I said, a great presentation. I mean, so many levels of practice change and program change that was covered here, from the practical to the culture piece to everything. Really, I think everybody's going to walk away with something. And if you didn't get your question answered, again, I apologize. I mean, there was just an overwhelming number of questions. We will do our best to make sure we connect you with them through their contact information that we will put on our Knowledge Exchange Network. The Knowledge Exchange Network is also where you can you will be able to find the recording. It usually takes us a couple of days to get that recording up, as well as a copy of the PowerPoint PDF of the PowerPoint slides, etc., and anything else, any other information that we can put up there. And just to remind you, we do our webinars every Wednesday at 11 a.m. Eastern Time. Next week, on May 22nd, we'll be talking about connected care, improving transitions, and building capacity in home and community care for children with medical complexity. And for that presentation, we'll be welcoming a team from the Connected Care program at the Hospital for Sick Children in Toronto to talk about their program, which is focused on 3 pillars of service around pediatric education for families pending discharge and workshops for home and community nurses. Virtual outreach, so hosting 24/7 real-time consultations, and bridged transition, so supporting more families with safe and quote-unquote warm handovers of accountability from sick kids to their home and community providers. So I think potentially lots of interest from the folks who participated here today. So thanks again for coming today, and hopefully we'll see lots of you back here next week. Bye, everyone.
Thank you.